And for this first session of day 2, we'll dive immediately into the action. And I'm happy to introduce our panelists. So we have today Campante Teles from Lisbon, and we have Mohamed Abdel-Wahab from Leipzig. Both are very dear friends, so thank you very much for joining me. And before we look at the case details, we'd like to open a poll for the audience. So TAVI in young operable patients. And young, we mean age under 65 years at low operative risk. What are your thoughts about it? A, it's obsolete and surgery should be the only option. B, it is a valid option, but the patient needs to know that surgery will be necessary if the transcatheter valve fails over time. C is a valid option, and there may be transcatheter options if the transcatheter valve fails over time. Or D, can be a better option than surgery based on upfront CT planning, and that is why all patients with symptomatic severe AF need to undergo CT planning. So take some time to answer these questions, and as you are digesting, I will give a short introduction of the case that we are about to see. So if I can get the slides in front of me, then we can briefly run through them. So the patient in Copenhagen is a young patient, but age doesn't tell you everything. So it's a 62-year-old male with a normal body size, with a past medical history or a medical history of LV dysfunction, ejection fraction approximately 35%, but severely depressed lung function. So COPD gold stage 4 with a forced expiratory volume in 1 second of 36%. So patient has severe complaints of dyspnea, and complaints have been worsening. There is also now angina, and the patient was turned down for surgery because of the advanced lung disease. By echo, the ejection fraction has increased to 45%. It seemed to be a low flow, low gradient, so they did a dobutamine stress echo, and then the severity of the aortic stenosis was like a mean gradient that increased to 42 millimeters square, and the valve area approaching below 1 millimeter square. EKG was at an unremarkable coronary artery disease, also in the lab biochemistry, no major issues that's there. And then the CT analysis, as you know, this is mandatory for the planning of CTs, and in my opinion, it should be mandatory for every single patient who undergoes a valve replacement for aortic stenosis. Well, when they look at the annular dimensions, the perimeter is around 85, the LVOT more or less same sized. And then we also, if the slides would work, the sinuses of Valsalva, they are maybe a little bit smaller, but still wide enough. And then it turns out that we're talking about bicuspid disease, and this is not a surprise. 62-year-old patient, so you might expect bicuspid here, and indeed, this is a Sievers 1 with a raphe between the left and the right coronary cusp. That is the most common phenotype of bicuspid aortic stenosis or aortic disease in Europe. And what the team has done, they made some additional measurements at the intercommissural level, so 4 and 8 millimeters above the annular plane. And you see that the dimensions there seem to be somewhat smaller as compared to the annular dimensions. So here is a run-through, a dynamic run-through through the ascending aorta from top to bottom into the annulus and into the LVOT. You can appreciate the bicuspid and the raphe. Coronaries look nice. I'm surprised there's not that much calcium, but again, patient is only 62 years old. Still trying to get the slot. So the coronaries are way up there, so no issues apparently there. And these are the optimal projections. I think it's very wise to look into multiple projections. So one point we were only working on coplanar, then we were only working in cusp overlap. I think we need to merge. And I agree with this Copenhagen approach to use even 3 approaches. I also have added a left coronary cusp isolation view, so that makes total sense. This is the arch. It is of interest, so this makes me think that we're also going to see embolic protection. And then the femorals seem unremarkable. for a transcatheter valve. So the procedural plan is transfemoral TAVI under local anesthesia, pre-closure with sutures, a pre-dil with a 23 millimeter balloon. And then the debate is this going to be an Evolut FX based on annular sizing? And that would then result in a 34 millimeter valve, or should we adjust our sizing algorithm because it's bicuspid and also take into consideration the dimension at the commissural level, at the Raphe level, and would that require then a smaller valve? So that's going to be an interesting discussion, and I think also a very nice feature of this case will be an IVUS-guided decision-making in terms of the need for post-dilation. So with that, I think we are getting ready to go to the lab, but they also did, and this is maybe also of interest, they did some computational modeling, so some simulations of how the valve would be seating in the annulus and in the ascending aorta. This helps you interpret, so in terms of borderline sizing, how the result will be in terms of paravalvular leak, but you can also then play with the implantation depth. So you can aim for a very high or a more intermediate implant depth. And that can also have consequences in terms of contact pressure that will help you then also predict the risk for pacemakers, for permanent pacemakers. So here you can see that obviously the lower you get, the higher the likelihood of pacemakers, and especially if you do more overstyling. So these variables all need to be balanced in the final decision making, and we're going to see how the team in Copenhagen is going to help us. So Ole and Gintas, before we go to you in 30 seconds, this is the result of the poll. So the majority of people think that surgery is not the only option in these kind of patients. And a quarter says, well, TAVI should be a valid option, and TAVI is also an option if the transcatheter valve would fail over time. 40% of the audience believe that, yeah, at one point you may need surgery, but that's not a problem if the patient is well informed, even a younger patient, that at one point in time TAVR can be necessary, then TAVI is also a good option. And a quarter say, well, we just need to do CT planning in all our patients, regardless of the treatment strategy. That said, I think we have covered everything that we wanted to cover in preparation of this live case. So it's high time to go to join Ola and Giritas and the team there in Copenhagen. Okay, guys, we can see you. Can you hear us too?
We can hear you, and welcome to Copenhagen on this nice and sunny spring day. We hope you will enjoy the case that we have prepared. Let me introduce briefly the team. My name is Gintas Pilauskas. I'm here together with my good colleague Ole De Backer, whom everybody knows. We have a team of nurses. We have Ida, we have Loni, we have Mette, we have Bettina, we have a couple of fellows, Enrico here. And Yusuke, you see on the other, well, you don't see it, he's on the other side of the camera. We're about to show you, okay, Ole, maybe you can tell what have we done so far? What have you done here? What do we have?
So we have 3 accesses. So we have a venous access on the left groin. This is just a 6 or 7 French sheet with a pacing lead in. This can be discussed. Do you pace on the wire or not? But we have more and more back preference to go pacing on a lead, balloon-tipped pacing lead. We have a radial access for the pigtail, and we have the main access. And as you see, this case is planned indeed for an Evolut 29 and 24. We can discuss. I think we will go probably for the supraannular sizing, the 29. So then this fits into an 18 French sheet, and then we have also there that can also different approaches. You can either go sheetless in with the integrated sheet, or we have a big preference actually to use a sheet. This is just an 18 dry seal sheet. So we're at that point now.
Yes, we're at this point in the procedure. Access is done. We have AL catheter in the ascending aorta and pigtail in the ascending aorta as well. You can see the C-arm is angulated to the cusp overlap view right now. And we are very happy to cross the valve in this view for regular tricuspid anatomy of aortic valve, but also especially in bicuspid with type 1 with right-left fusion. As you can see, Ole has already found the way into the ventricle. We would most of the time use exchange wire in the pigtail for further as a further step. Some people might use immediately a stiff wire, but we still like to use this intermediate step with a pigtail, both to take some hemodynamics and hopefully to make the procedure more safe, even though perforation of that left ventricle maybe is not that usual, regardless of the approach. So what you see right now is a soft, long exchange wire in the left ventricle, and pigtail is following soon after. We'll do some hemodynamic measurements.
And even indeed, I mean, in a bicuspid, we try to do most of the manipulations as you see. This is now a type 1 right-left fusion, so that fits perfectly with the right-left cusp overlap view. You will see us doing the crossing, the pre-dilatation, most of the expansion of the valve, and if we have to pulse dilate, all in this, we call it the commissural view. So the view where you look into a commissure. Just before this case, we looked at a couple of, we have actually a lot of bicuspid cases every week. So we looked at a couple of other bicuspid cases. So if you have a type 0 or a type 1 right non-fusion, we always try to look and find on the CT the commissural view, the view where you look into the commissure. And that's the easiest, we feel.
So now we connect pressures on both aorta and left ventricle. Let's see.
We can look at the hemodynamics.
Let's see how that hemodynamics follows. I hope you see it on the screen. Let's see if we can have a run with less extrasystolic activity.
We have clearly high gradient.
We have clearly high gradient, especially post extrasystolic is very high. But even now, it's good. It's good on. It's good. It's good.
A little bit back. Yeah,
it's good. Let's take the measurement here. We measure. So we have the gradient is 37 peak, and the separation between diastolic in aorta and end diastolic in the ventricle is 34. So we remember that for future reference.
Yeah. And this man has a reduced reduced ejection fraction. He has systolic, I think it was 35 to 40 maximally on the last week described echo.
This also brings us, back to the discussion about the pacemaker. Of course, people sometimes there could be some argument not to even puncture the vein, but here in Copenhagen, the setup is complete local anesthesia. Patient is not sedated. We don't even have anesthesia team in the room. So that venous access in the groin, for us, it functions as kind of a central vein. We are even connected with fluids and noradrenaline, just in case we don't give it, but we have it ready for any...
We may have to give it.
We may have to give it.
If we look to its pressures, even without doing anything, it's hardly systolic 100. So looking at this, having not done the predil, I would even consider in such a patient to give a small, tiny background doses of noradrenaline.
I completely agree. It's better to prevent things from happening rather than have a hemodynamic crash.
Let's put it at 2.
So let's put it 2 indeed. That 2 is the infusion rates for our dilution. It's a mild, small dose of noradrenaline that we are starting right now, just a small preemptive effort to keep his blood pressure in order. We're still staying the same cusp overlap view, and we come with a balloon now. By the way,
he has a very sensitive ventricle.
He has a very sensitive ventricle. We try to balance the wire properly. The balloon is 24 in this particular case. We might consider, do you want to use it also for sizing effort or not really? What's your take, Ole?
Oh yeah, we can ask the panel maybe. I mean, do you think, because indeed this is a doubtful case, really, really doubtful case between 29 and 34. 29 is almost just a tiny bit too small. 34 we feel is just a tiny bit too large. So there are different sizing modalities, of course, you can do on CT. But one thing you can do also in rare cases is during a pre-dilatation inflation of the balloon, we can give some contrast, and that can be some kind of dummy to test. Yes, so
and we have already taken decision regarding the valve, but if we would not be happy about what we see, we could still change that decision. We could still say, okay, our decision maybe is not good. We can still navigate away from it.
Let's check if Nicolas can hear us. Nicolas, can you hear us?
Yes, we can hear you. So Mohamed, what is your take on this? Mohamed.
Hi, Nicolas. Hi, Rui, Ole, Gintas. Good to see you all. I'm not really sure how I can size with the balloon, but maybe you help me. I don't use it. And then I'm not really sure. Now you're taking a 24 millimeter balloon, but at the end of the day, you're taking a much bigger valve anyway, correct? So if this balloon is sealing, we're not sealing. How can this help us decide between a 29 and a 34? I'm not sure.
Mohamed. Okay.
Well, so I can elaborate. Normally, the way we use balloon sizing, if you would, so your question is, is a 29 valve okay or not? Because normally annulus would suggest 34 and we're taking 29. And we know that 29 normally has formal upper range limit of perimeter derived 26 approximately. So technically, if you would take a 25 or 26 balloon and it's fully sealing, that would suggest that in that anatomy somewhere, the 29 valve should also seal. 24 is smaller than that. So of course, it doesn't fully exclude the suitability of 29. If we have 24 balloon and there's still small leak, we could still have a question, maybe a 26 balloon would seal. And we have discussed, should we use a bigger balloon or not? But here the balance is in favor of smaller balloon. Yeah. We did not want to go larger, but we could still a little bit judge something about the smaller balloon as well.
Yeah, and Mohamed, to make it very easy, look, if a 23 balloon goes up and you give contrast and there's absolutely no leak, that would mean that the balloon expandable 23 would also do the job. And a balloon expandable 23, that covers exactly the same as a self-expanding involute 26. So that's a little bit how you can use it, I think, yes? So if a 23 or 24 balloon would give some leak, then we may start to doubt a little bit that our downsize strategy is maybe sufficient for this man.
But of course, our evolute is not 26, it's 29. So
I know.
We are smallish for the balloon.
So,
indeed, we could take a bigger balloon.
So guys,
okay, let's.
I understand
we move on.
I understand the rationale, but I don't think it's a waterproof method. To be honest,
No.
It's quite controversial. I never do it. To be honest, I've walked away from that because it's in the eye of the beholder. It depends on so many factors that determines whether or not you will see some leak around the balloon. Rui, are you still doing this?
Yeah, I'm the one that I'm still doing this. Not often, not as a. I think that in these cases, it is reassuring that you don't have any sort of PVL around the balloon, and in that case, I think in my mind, 29 is the proper sizing in this case. Also, due to the, and it's not quite cylindric, but it's slightly tapered, I think. But from what I understood, but in the end, this is reassuring regarding the 29 core valve size in my mind. Of course, if then there is some sort of leak around the balloon, then what you decided after that is the problem. But once you have an occlusion, that is for me is something that helps me to decide in ways out. Anyway, I think the case is a very nice case regarding the technical discussion here.
Yeah, so you see here the 24 millimeter inflated and contrast given. I mean, yeah, 24 is definitely sealing fully. So it confirms, I mean, I fully agree with Nicolas. This is not a waterproof solution. It's more like an extra test intra-procedurally, I would call it, even if anything, if it's worth anything. But indeed, we also trust mostly on our CT. And you see here, we trusted mostly to go on the supra-annular sizing. We actually downsize from this perimeter 85, which is clearly within the territory of a 34 valve normally. So now, of course, he's a young patient. He's 62 only. So it's relatively important to try to do commissural alignment. So here we go in an LAO. We have the head marker on the outside. I continue. Gintas holds the wire nicely. The arch didn't look any complex on the CT.
We're dragging our pigtail together. We'll see. We might need a J wire just in case. Let's see. It's okay. We take a wire, Ole. Maybe.
No, maybe.
You'll need
I'll need a wire probably because it's around the system.
Maybe
let's do it now.
Let's do it now. Okay. So I'm gonna go to cusp overlap so you see where to go.
You can go to cusp overlap already. You see the pigtail from the radial that's wrapped around my system. But this is better. Yeah, this is good.
Oh, wait.
Yeah, but the sinus is such a bit. It did it from in the beginning. Okay, I think it's good enough.
Okay.
A little bit forward on the contrast, please. Yeah, all right, it's good. Okay, good. Now we're in cusp overlap, not fully yet.
Almost. There we go.
Yeah, all right, good. So I advance a little bit more. You hold the wire.
Hold the wire.
Pigtail doesn't sit fantastic, but that's sometimes the case with radial, of course.
It's enabled.
Okay,
yep.
Good. All right, I think we're going to go
The head marker is on the outside, which is, I think, a good thing, huh?
Well, it should normally.
Well, it should be in the center because now we're in the cusp overlap, so it should be in the center normally.
Oh yeah,
almost is. It's slightly.
It almost is.
Almost is. Not that bad.
Okay, let's. It's bouncing quite a bit, so let's pace a little bit. Even though the radial pigtail is not very
120
stable.
pace on. North rail in 5.
All right. I'll give a little bit of contrast here.
That's okay. That's
Pretty good.
And I would want to be pretty high here.
Yeah, I
like
agree, I
normally
agree.
it's like 1 millimeter below or so.
I agree.
And I can use my wire to push you up if necessary, because you seem to be pretty vertical. So let me use the wire to adjust if it dives. 140 pace.
Pigtail comes up a little bit. I feel like that pigtail is not fully stable. You see that?
Yeah, now better.
Yeah.
We can maybe make one more
Yeah, we'll
shot
take
soon.
soon a shot again. We're pacing 140 now.
Yeah, this is perfect.
Probably good. 160.
180. Don't push, it's okay.
Yeah, that's good.
Okay, it's okay.
And 100. Yeah. All right. So, it came up. Yeah,
Okay.
because there's very little calcium. Yeah.
All right, so we'll reposition once. Okay.
That's surprising.
We thought we
But you
would
see, there's not crazy much calcium, and we're of course undersizing.
Yeah.
That's it, eh?
Stop it.
That probably contributes to the risk of embolization.
Yeah.
Because at the annular level, you are now undersized. You're properly sized at the commissural level or at the level of the commissures, but you're not at the annulus. So I think that can work a little bit against you.
Slower, like we keep some pace.
Yeah. Look, I mean, to
Yeah,
be
but
honest,
I mean, also like
a
the
nine
graph
position
or
is
a
center.
really
That's
more or
fine.
less.
Yeah, okay.
The RAFI is a bit short, so it's like, I think it's a partial fusion type. The RAFI is not also very heavily calcified. So there are a lot of challenges, I think, for the smaller valve here as well.
I agree. And don't forget, you also used a 24 millimeter balloon now, and there was not so much calcium. So it's going to be tougher to interact with that low calcium volume that is there. So I need you to do a little bit prolonged pacing here.
Great. Go. 160, 140, 120.
Well, that pigtail
100.
definitely came up again.
So
now on purpose, I went a little bit deeper. Normally on a bicuspid, I really like to implant really high. But here, because there's so little calcium or less calcium, I had to go a bit deeper, to be honest. But look, I mean, I'm sitting reasonable still.
this is nominal depth. Yeah, like 3 millimeter depth in the none.
And I keep my hand on this catheter.
Yeah.
So now we go to the left isolation view, which is an LAO 50. I think that's also important to do that, to really check. But of course, we're going to be, that's good enough. Yeah, and we have that's great.
Yeah.
Okay.
That's very good.
It's
That's actually
reasonable.
Very good. That's very good.
And let's do a three. Then I would like to finish off in a tricuspid corrected with a parallax. Yeah, I'll zoom maybe even one out, otherwise you won't see it maybe fully. That's more to judge how central I am in the... Yeah, it looks reasonably nice. I mean, the catheter is nice in the center of the aorta. We're sitting around 3-ish. It's lower than I normally do in a bicuspid, to be honest. There's no tremendous leak. You see there a tiny bit. Maybe it needs an extra pulse, but I would probably dare to accept this.
Like the thing is, this is like nominal implant, 3 millimeter or so,
This is
3 maybe
overlap.
4. This is cusp overlap. This is left isolation right now, and this is somewhere in between.
Tricuspid.
Tricuspid.
You see it, we have nice commissural alignment,
Yeah.
but okay, that's secondary.
Of course, we have downsized to 29, where hopefully the tendency of diving will be less pronounced because it's less tapered, that valve.
Also, SC junction is around 29, so that's a good thing too.
Yeah.
I would probably accept this and go for a very slow release and keep a little bit of, I would not pull back on my wire. Yes. So that's what I would do.
Because we only have 2 options now. We can either accept or go higher. These 2 options we are discussing. And of course, by going higher, we just saw this maybe tendency to pop out a little bit. So it's not risk-free to go very high. So in that context, probably we should accept.
I think so. Is there any other voices? I mean, patient is super stable, so you can give some comments if you want. Would somebody not release?
Yeah.
Well,
I would just,
from my point of view,
what you would do to make sure, or to make sure that it's not going to dive while release. So like if it remains like that, it would be perfect, but it could dive a little bit into the ventricle, correct?
So Mohamed, would you go higher a little bit? We can do that, but like, would you accept in this specific situation? What do you think yourself?
Yeah.
Yeah, you don't know. That's the thing. We also don't know.
I mean, probably I would.
we go higher normally, but here it popped up once. There's mild calcification. I don't feel comfortable personally in planning at 1 millimeter, and now we have around 3. I think we have to accept this.
Yeah. So but as Mohamed said, if it stays like
so
this,
Ole,
it's perfect. If it dives, it's less perfect.
Let's release it.
I think I agree with you, Ole, but at the same time, it's also a nice illustration how you're doing concessions now because you opted for the smaller size, right? So I can imagine that you would have felt more comfortable with a higher position if you would have selected a 34 or the large valve. I think. That is why in most of my cases, I still do annulus sizing, especially based on the measurements that you had. I was not so impressed with the sizing difference between annulus and the commissural levels because there is just a higher risk of embolization. Now, also, if you need to post-dilate, I also would not feel 100% comfortable. So let's see what happens.
Yeah. No, I see your point, of course. And
just
that's why
say, I'm on your side. I think you are doing a good job. And I think since you had the embolization, I would do exactly the same. I would prefer to have an higher implant. But here you are really, I think it will be stable.
You see, we do this very slow. Do this very slow. And now it's off. Of course, let's stop pacing. We even didn't pull back on the wire, yes, as you see. So we even had a tiny bit push on the wire, if anything.
Like it was neutral. It wasn't pushing.
Yeah,
it was
neutral,
kept as it was. We did not push on the wire, did not pull. We kept it neutral.
Okay, let's get it out and then we make an assessment. Yeah.
Let's carefully we walk it out. Let's see.
Yeah.
We stopped noradrenaline completely.
Visually, like let's disable. Visually, I don't think it moved anything. To be honest, it didn't go down. I think it only tilted a little bit, yes. So with the final release, what it sometimes happens is that the valve, because it goes, of course, it follows the aorta, so it tilts, and by the tilt itself, it typically goes 1 or 2 millimeter lower, yes. So, but it didn't dive, and again, that's something what was against the 34 for us because it was a tapering, wide open tapering LVOT, and the LVOT, the annulus was perimeter 85, the LVOT was more even 87. So going for a 34, we have the feeling we get more diving, and that's why we wanted to stick to the 29. Also, the ST junction was 29, so we thought it was good, but I agree on the other hand, was very mild calcification. So to be honest, I mean, if I do a bicuspid, I almost prefer to have a lot of calcium, not excessive, but a good amount of calcium. I like, because you have extremely good anchoring.
But indeed, I also completely I would say that stability just by taking a bigger valve is not necessarily guaranteed. It could be the other way around. That, you think you oversize more and it will be more stable. And sometimes it is, but not always. Like it's also, if that would be universal rule, it would be easier, but it's not, unfortunately. Sometimes bigger means more stored tension.
So now maybe have the IVUS on the... Look, one thing I have to declare, this patient is included in a trial in the OPTEX TAVI trial, which we're running. We have around 300 patients included already. It's going good, but this patient is randomized to the OPTEX arm. So that means optimized expansion arm. That means it's mandatory to do pre-dil, valve implant, posal. So this is bottom, you see the IVUS images.
Bottom leaflets.
Yeah, mid leaflets here.
Mid leaflets here.
And then top leaflets there.
Top leaflets there, yeah. Okay.
All right, you have it. Okay, good. Out. So we will have to pulse-dilate this patient anyway. Yes.
In a trial context, yeah.
In a trial context.
Because the hypothesis is, whether or not routine post-dil is beneficial.
And look, this is from a very REO. We know typically you see the most constrained aspect of the valve in an REO, even more REO than cusp overlap. Typically you have to add 10 or 20 degrees REO. So this would be this. This is REO 35. To be honest, this valve looks pretty nice expanded because, again, there's mild calcification. So maybe it's not really needed to do a pulse-dil. But anyway,
I would not be surprised to give it a small push still.
Yeah, we will maybe still give it an extra millimeter push. And actually 1 or 2 millimeter push doesn't sound a lot, but if you look at and if you calculate it in area, this is typically 2 millimeter expansion is typically 20% expansion of the stent frame. So maybe that's the whole study. Is a better stent frame expansion good for reducing leaflet thrombosis and improving valve durability? That has to be seen. Of course, we also have to be careful there because, you know, for the evolute, if we take a too aggressive pulse dilatation, that can also be negative for the leaflets. And as we know from the evolute low risk trial, of course, so it's finding a good balance there. I will make an injection here. Yeah, that's great. And it didn't, we can even give more contrast, to be honest. But look at the valve didn't go down at all. Yes.
So let's do pulse dilate, and you want more now?
Yeah. Well,
so
we then could do pulse dilate and we can repeat the
we'll
injection.
repeat it after pulse,
and it sits around 3 millimeters.
We'll pulse dilate anyway.
Okay,
in
let's
a trial
pulse dilate.
context, yeah?
Do we have the time for that, Nicolas? To do a pulse dilate?
Yeah, you have plenty of time. Plenty.
Oh, we have plenty of...
Hemodynamics is just taken, so if anything, there's a small gradient, less than 10, single digit,
Oh, really?
but 8 millimeter gradient is shown, 8 millimeter peak to peak. Very good separation, by the way, suggesting no significant leak, like separation in diastolic pressures is very, very good. So that's already very optimistic. That we will.
And then for discussing just 1 minute commissural alignment. Look, this is the cusp overlap view. So I'll give you a small cine. This is the cusp overlap view. So we have perfect commissural alignment. You see, we have 2 commissures pointing to the left, 1 commissure pointing to the right on the fluoro screen, where the right and the left cusp are overlapped. So we have, for this patient, it's important, I think, 62. That we can get easy coronary access. And not only that, if we have to redo TAVI on him, we can easily some leaflet modification.
140
yes?
on.
Okay, so we will do a pulse-il. Of course, for the pulse-il, we're always a little bit more neurotic on good capture than for a predil. For a predil, I think you come away if the balloon jumps up, it doesn't matter.
Pacing.
But if you do a pulse-il, we are very picky on having really good capture.
Frequency 220.
We know also this patient, he was bicuspid, we had to pulse dilate him, so that's why we also used a pacing lead, to be honest.
220.
Okay, we're gonna pace.
Okay, I'm ready. Pacemaker ready. You good?
Yeah, I'm good, yeah.
Pacing on. Let's see if there's good capture. Make sure you pace. We don't see it. Now it's coming. Now it's coming. Let it run a bit. Well, wait. It may. Yeah, there's good capture now. I can go up. Agree?
Yeah, go up. Yeah, down. Stop pacing. Yeah, stop pacing. Yeah. All right.
Okay, so we still gave it a push. I mean, that was obvious.
Sure. Okay, let's do the IVUS. Maybe, Juske, you have been tracing the inflow. What was the inflow, for example? What did you measure on the first tracing of the IVUS?
Could you unmute? Can you hear us?
Otherwise, you can tell us. We can say it to the...
Yeah, so then the minimum diameter is at 22.6 and the max is at 25.6. And the area is at
22.6 by 25.6.
Yes.
Okay, let's repeat it. It's going to be interesting. Of course, this is the inflow, but it's going to be interesting. So 22.6 by 25.6. I remember this is a 29 valve, yes?
Or you can remember area 463. Area 463.
Okay, let's have a look.
So we can compare area. That's going to be very easy.
All right, good. All right, we go up with the IVUS again. And then we're kind of finished, I think, after that.
We still make injection because part of the
program. One question, Ole.
Yeah.
Outside of the clinical trial, would you perform this valvulopathy just because this is, of course, a case where you seem to have achieved a pretty good result so far?
Leaflets.
Yeah. Yes, I agree. Well, I would say 99% of operators would not pulse dilate this case. I know. Leaflets. I think in Copenhagen, almost bicuspid and valve-in-valve cases, we have a rule here that we almost always pulse dilate. But of course, that's not based on big science. That's why we do the OPTEX trial. But I mean, we have to have a really good excuse not to pulse dilate in a bicuspid or a valve-in-valve scenario, I would say. So
excuse could be, excuse of embolization, for example.
Yeah. Excuse could be very, very high implant that you're afraid of valve embolization with the pulse-dil, or borderline you see the conduction disorder already, that the patient had some transient small block or so. So this could be all reasons not to go for a pulse-dil. But I think, let's see. I mean, if we had a further expansion on the inflow, there we have it.
Yeah, so actually the max is very similar, 25.9, and the minimum is at 20, almost.
So look, in area, we had 460,
now it's
490. So we have around
30.
6% further expansion. And indeed, this is on the lower end, because we have done now 150 series of IVUS pre and post dilatation, and typically we get 10 to 15 or 10 to 20% further expansion. So this is on the lower end.
Ole and Gintas,
Yeah.
obviously, yes, you have some increase now in your area, but at the same time, you also can take into account the nitinol properties, right? So if you implant a nitinol valve, you can expect in the subsequent months to even years that the nitinol will continue to expand further. So I think I agree with Rui that the result was already quite favorable from the get-go with single-digit gradients and no PVL. So I wonder.
Yeah, but agree. I mean, look, this is discussable. That's why we do the trial. And I'm also, in this particular case here, I'm also in doubt, to be honest, if it really was beneficial or not. But we will see in the trial if it's of any harm or not. Yeah?
By the way, single-digit gradient disappeared. So, like, this was also helpful hemodynamically. Now our gradient is 1. Instead of
so
close to 10.
invasive 1, and we had pre-TAVI, we had a separation 34. Now we have 36 separation. So that's improved. Maybe I can just take out the pigtail here. We don't need it anymore.
But the other one is taken together.
Yeah, I hope not.
Yeah, it is.
Yeah, it is. I'm just bad luck.
Yeah.
Okay, then give me a J-wire.
Well, we can connect to this pigtail.
Yeah, indeed.
That's easier. Take that out.
Yeah.
We just
And you know,
connect to
the other argument, Gintas, for your post-dil strategy and to strive for perfection here is that you decided to downsize a bit, and obviously the concession that you make is there is a higher risk of prosthesis patient mismatch then because you go for a lower sized valve. So I think that is also an argument in favor of then post-dilling again.
Yeah, true.
And the trial will tell, we don't know. Like, that's the reason we do the trial. It could be like with coronary world. I mean, maybe it's universally good. We don't know. So that's a hypothesis to be answered.
Yeah. Look, now we give a very, very good injection.
Oh, man, that's perfect.
25 cc at the speed of almost 15. So this is, I mean, there's no leak.
It stayed same look,
it stayed at 3 millimeter.
It did not move down. And there's zero leak.
So we have commissural alignment. So I think for this man, I mean, he has perfect hemodynamics, no leak. I think I'm happy with this. He has a really nicely expanded frame as well. So I'm happy with it.
We can show from the left how does the frame look in another projection. We don't need to inject, but we can just show. So it's the AO projection. Yeah, it's also expanded. Not dramatic difference, but do not enable.
No, we're not going to give contrast, is it?
No. It's just to show the frame.
Yeah.
Okay. All right, so we're done with the valve.
We can close. If you have time, you can stay with us. If not, you can also go offline. But otherwise, we show you the closure.
We can go to the hour.
Okay, let's do that. So let's stay with us then. Then we have a closure still. Of course, we did in the beginning echo-guided puncture, logically.
We use one pro style to begin with. That's the traditional technique.
Then we keep us, let's say, explain in detail. So this is an unplugged super stiff wire. Why do we do that? Well, because if this goes out and let's say you have a major vascular complication or I rupture my pro style, well, then I would love to have an unplugged super stiff there because then you can go in with anything. Big sheet, a manta, whatever. If I have just a fluffy J-wire here at this moment, sometimes in difficult accesses where you have difficult puncture, you may not go in with your manta or your big sheet. So that's why we have a preference here at this stage to go in with our stiff wire. So now I'm preparing for the pro style. We can also think of giving protamine maybe, I don't know.
It's done.
If it's done already, okay, good. All right, fine. Then I'm kind of ready to... So now I have the single pro style here. Gintas will slowly walk out the dry seal sheet.
And Ole starts closing already on the dilator. We put dilator back in typically, and on that dilator carefully close. So it's usually very controlled. I keep the wire.
So I compress with my left hand. I keep some push on my pusher here. And then typically it almost doesn't bleed. You see it's like a couple of cc's only. Then the 8 French sheet goes in. Yeah, it's already almost too good closed. Yeah, you can.
It's okay.
Yeah,
It's
it's okay.
coming. It's okay.
Yeah.
It's all good.
You have some dry serviette for me?
Yeah. So now we check clinical external bleeding. Is it
Yeah.
yes present or not? And it's not.
It's already
completely
dry around the 8. So I know that some centers, they don't, you don't have to do this angio check. But look, I mean, we're going to give like something like 6 or 7 cc, to be honest. And then
8.
it's kind of a nice documentation, even legally. We're good. And then now we're going to see here, we're going to give a small injection through this 8 French. Yeah. And that looks great, yes. So there's nothing around this 8. So then we know this is good. We won't do any further control. You can close the fluoro, and we will just close now with an 8 angio-seal. Yeah?
Yeah,
All right.
8 angio-seal.
Yeah.
So that's kind of it. Maybe
Can we get
some
ECG maybe?
discussion. Oh, yeah, some
ECG is
ECG we want to
interesting,
see. In the meantime, you can discuss, Nicolas, with Mohamed, Rui.
Yeah, so I very much like this more conventional closing. I think more and more sites have adopted this this technique of 1 per close and then and then add on an angio-seal. I think it's almost bulletproof. There is also randomized trial data to support it these days. Rui, are you doing it in a similar way?
We are mixing the mental experience with this one. This is dominant here. But I think, of course, then it depends a lot. I think in all these femoral access strategies, it depends a lot on your background and training. Once you get used to do a good technique and you are confident with it, you can work with it most of the time. Of course, then calcification plays a role, the size of the vessel, etc. But I think this is an excellent closure. So I just want to take the chance just to say, because this was a wonderful case, Ole and Gittes did a wonderful job. It seems so easy, but it's not really, because this is a scenario where you have to take very hard decisions regarding the sizing and the valve selection. So the coronary height the coronary distance was quite high here. To select core valve here, this result for me was really a perfect result. If you consider all the options that we have to achieve, all the results that you want to achieve in such a case, what did you leave behind? Nothing. You don't have pacemaker. You have excellent gradients, no PVL, coronary access. Reintervention in the future might be possible, because I think the coronary distance is really high. So I think everything is open. So I wouldn't. There's nothing else that I could say that could be improved. So from my point of view, that is a lesson that we have to take. And of course, this decision regarding the sizing, the tapered anatomy was critical. In my mind, I think we all try to go for smaller sizing bicuspid aortic valves. We all always try to go higher in the implant, but actually here, even with a regular implant, he didn't achieve any sort of conduction disturbances, which was remarkable also. So it was really and it was not a low risk, because it was 62, but in the end, with the COPD and this ejection fraction, it looks that the patient was really stable. I don't know if he did perform any sort of infusion with inotropics or adrenaline.
Yeah, we did a very little. Yeah.
It was very small infusion of noradrenaline, like small dose, minimum dose noradrenaline. Yeah. By the way, meanwhile, while you were talking, I looked at the ECG. So there is completely normal PR, 150. And then we have left bundle branch block there, which is also measures 140, 150 in that range. So in this case, we would not leave any pacemakers in the patient. We would just ship the patient to the ward, and tomorrow with this, he could go home. That would be our strategy, yeah.
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 So any further
congratulations also from my side, Ole and Gittes. Like it, as Rui said, it looks so easy, but it's not. And I always learn a couple of things every time I see you guys work. So can I have like 2 or 3 minor questions?
Of course, please.
Of course.
Yeah. So the first one would be, how did the simulation, the FEOP simulation that we've seen, how did it help you to, or did it help you to decide between the 2 valve sizes, or was it like nice, but actually not very helpful? So this would be my first question.
I would say it's nice to have, but we made up our mind before. I have to say myself, I was really in dubio 50-50. Typically, I'm more convinced of downsizing. If this would have been tiny bit more calcified, or the RAFE would have been a tiny bit longer calcified, I would have had no doubt at all. Now a tiny bit doubt, and then having that simulation with the 29 simulated both high or even a bit lower, as here we ended up with the 3 millimeter. Yeah, it showed only a trace PVL. If this simulation would have shown me like a mild to moderate or moderate PVL, yeah, then I wouldn't have gone for this downside strategy, of course. So it just comforts me in my decision to downsize. But okay, I mean that it is worth for what it is. But that's what I have to answer on it.
I agree. I don't think I remember what the simulation showed. So
yeah, there was a trace with a 29 and no PVL with the 34. Yeah, but higher pacemaker risk with the 34.
And then Gintas wanted to tell us about the pacemaker, but I didn't. I think he didn't conclude why you are, like, as far as I understood, you shifted backwards towards using temporary pacemakers, correct?
Yeah. So yeah, indeed. So
did I understand this
first
correctly?
of all, that's easy explanation. So first of all, we always puncture the vein just to have efficient infusion of fluids.
Because
and
we don't have anesthesia.
Because we don't have anesthesia. So we need a vein, and we want to have it on the groin for hemodynamic management. And if we have the vein anyway for hemodynamic control, then putting the pacemaker is so easy and quick. And we perceive it as a more reliable tool, the RV pacer, compared to wire pacing. Wire pacing typically works. But like, you know, that one instance in 100 where it fails a beat and you end up in an unpleasant situation due to that is enough to convince you like to take a more reliable strategy. And that's how we think.
Yeah, I have no big feelings about it. I think 2/3 we put a temporary pace, 1/3 we pace on the wire. But look, I mean, this is a bicuspid patient. We have to pulse dilate because of the protocol. And indeed, in a pulse dil, you don't want to have any missed capture. So, I mean, and I cannot recall, honestly, I mean, the last couple of years from a right ventricular pacing lead, the wire you saw us using here with the balloon tipped, that we had any complication related to that. So, I mean, we're indeed 3 years ago, we were doing mostly pacing on the wire. Now we're shifting mostly back to pacing on the RV pacer, but still we pace sometimes on a LV wire, of course, as well. Yeah.
But those are flavors, right? I think you can also make the counter argument, just as you mentioned. Yeah, the temporary pacemaker, a zero complication rate doesn't exist. So you can balance those out. I think that's a flavor. Where do you feel comfortable with? I'm still a proponent of continuous LV wire pacing, and it's not that I have an epidemic of embolizations or anything. So and then your third question, Mohamed, what was that?
Yeah, my third question, but maybe I didn't see it correctly from here. But what type of wire was that? Was that a safari wire? It looked a bit different than a safari
wire. That was a very well seen. Normally we use in almost all the cases safari. No, very well seen, Mohamed, because normally we use 99% safari. Unfortunately, just yesterday, I guess, we used the last safari and we didn't have any new ones on the shelf. This was a circular wire, circular from Abbott. The thing is, indeed, now I don't have gloves anymore on. It's just in front of... Can you give me gloves? Because then I can show it. Just see it laying in front of me. The thing with this wire is, they say it's extremely similar, and indeed it's true. It's very similar as a safari wire. But there are slight differences, actually. And I don't know, it's discussable if this is favorable or not. I personally, it's maybe just habit. But look, I mean, this is the circular wire. So first of all, what I would say is that the curl is a tiny bit larger than even the Safari Small. It's a tiny bit wider. So I'm not sure if I like that. Maybe I give the answer by formulating it that way. But especially the thing is, the body of the wire is actually a little bit less stiff than a Safari. And I think, to be honest, I mean, if anything, if you would design the perfect wire, I think Medtronic is coming soon also with a wire. What you need is what I like, a very stiff body of the wire. It just has to be a relatively soft in the ventricle, but all the rest that goes all the way up to the ascending aorta, that can be for me as stiff as a Lundquist wire, and that's just not. This is a little bit softer actually than the Safari wire. So in a way, it's not my favorite wire, but again, it's not a bad wire. It's a proper wire, proper stiff wire. But okay, it was very, very well seen, Mohamed, and indeed, it's a slightly different wire than we normally use, or than a Safari wire. Yeah,
Felt okay. I mean,
it felt okay.
there was no problem.
No problem.
Yeah.
No, I think to conclude, guys, Gintas and Ola, I think this was a very nice demonstration of, maybe the more challenging TAVIs that we do these days. This is bicuspid aortic stenosis, and I think we had an added challenge with the low calcium load. And I think that also was an additional item that we needed to take into account when we were also choosing for your valve size. We discussed during the procedure what are the pros and cons. I think we also covered the need for repositioning, what would be the risks. But I think at the end of the day, you have a perfect result with no gradient. You have no paravalvular leak. You have nice commissural alignment, and then everything done in well within the hour, and you were not even rushing at a single moment. So I think a very nice demonstration of how TAVI should be performed in 2026. So thank you both. Thank you to the entire team. This was a masterpiece. Thank you very much. And we'll see you in an hour or so.
Thank you. See you soon for an LA closure. Yes.
Bye-bye.
Bye. Thanks, Nicolas, Mohamed. Bye-bye, everybody. Pleasure.
Okay, so this was a fantastic case. So let's now move to the next session for yet another live case. And then we'll meet again with Mohamed and Rui in a second.